Hello and welcome to Best of the Day from the 2013 ASCO Gastrointestinal Cancer Symposium. This is the 10th anniversary of the ASCO GI meeting, and there is a lot of review over this meeting of what has transpired in gastrointestinal cancers over the last 10 years. And when you sit down and think about it, there has been a lot that's gone on and a lot of progress. And today was the upper GI day. Carcinoma of the esophagus, cancer of the EG junction, gastric cancer. And so joining me to talk about what was presented and discussed today is Dr. Joanna Bendell from the Sarah Cannon Cancer Institute in Nashville. So Joanna, thanks so much for being with us once again.
Thank you for having me.
Well, this is always a really enjoyable meeting. It's not nearly as crazy as the main ASCO. Everybody is in one room. The attendance at this meeting grows every year, and it's very multidisciplinary. So I think almost 20% of the attendees are surgeons this year, and a lot of radiation oncologists, a lot of gastroenterologists come. So it's really interesting, and it's a slower pace. I think it's a great learning opportunity for the attendees.
Absolutely. I think there's so many great educational sessions, ways that people can catch up on what's happened in the last 10 years. We've had amazing talks today. And I think also it gives this chance for us to be multidisciplinary and interact in a multidisciplinary fashion. So we can look at esophagogastric cancers from diagnosis through all of the treatments.
Right, and they talked a great deal about some of the things we do now, and we believe that back in 2003, 2004, we didn't know about. And of course, one of the big things is the role of HER2 positivity in gastric cancer. But let's start off with talking about the advances in chemoradiation and how that has changed the therapeutic landscape, especially for esophageal and gastroesophageal junction carcinomas. So where do we stand? Is there a role for just induction chemotherapy followed by chemoradiation for locally advanced disease, or is chemoradiation alone the standard of care? And for patients who are resectable in the beginning, do they need chemoradiation post-op? Do they need just adjuvant chemotherapy post-op? Where do we stand on those questions?
I think it's funny because we stand at a lot of spots with those questions, and a lot of it is dependent on the institution where you are. A lot of it is dependent on what your presentation is, and some of it is dependent on what country you're in.
Right.
And so when you look at the United States, standard of care for esophageal cancer is to do neoadjuvant chemoradiation, then surgery. For patients who are not surgical candidates, we do use definitive chemoradiation therapy, and we've seen from previous clinical trials that we do have some long-term survivors who get definitive chemoradiation therapy. In Europe, however, you may see some esophageal, esophagogastric cancer patients treated with neoadjuvant chemotherapy, followed by surgery, followed by adjuvant chemotherapy.
The MAGIC trial.
The MAGIC trial, exactly. And they still are building on the results of the MAGIC trial. But where we end up is that we're not quite sure which is the best modality. When you look, for instance, at the intergroup 0116 study, which is where we finally got proof that we should use adjuvant chemoradiation therapy for gastric cancer patients, there was a great variability in the surgery that was done for the resection. And so we don't know if the chemoradiation therapy helped because it cleaned up after less optimal surgery,
right,
or if there's some inherent goodness to the chemoradiation therapy. We also don't know, should we use it before treatment or before surgery or after surgery, because we've seen from other clinical trials that once patients have surgery or gastric or esophageal resections, they tend not to be able to tolerate the chemoradiation therapy or chemotherapy as well adjuvantly.
right.
So is there a better way to get it in pre-operatively than wait till post-operatively? So a lot of these questions still remain. Now, when you look at some of the trials that have come out, the problem with some of these trials is that there's been low accrual. And so you have people who are designing the right trials, looking at preoperative versus postoperative chemoradiation therapy, but the trials don't get enough patients on them to be able to say anything definitively. Where we are right now is we think that chemoradiation therapy will give better local control than chemotherapy alone. However, we haven't seen that necessarily translate into a randomized phase 3 survival benefit. We also know that chemoradiation therapy is more toxic than chemotherapy. So it really depends what your gut, no pun intended, instinct is.
Right.
And for now, we stand with, in the United States, doing the chemoradiation therapy, surgery, and then potentially chemotherapy depending on the location of the tumor. But to say that one way is the set way and the standard way, I don't think we have that answer yet.
And does the decision regarding post-op adjuvant therapy also depend upon the response to chemoradiation?
Yes and no. So when you look at esophageal cancers, for instance, by the textbook, we give chemoradiation therapy, we do resection, and we don't give any postoperative chemotherapy. For gastric cancers, we potentially will give adjuvant chemotherapy. Should that response initially determine whether or not you give that chemotherapy, we don't have that subgroup breakdown necessarily, but it makes people wonder if you had progression during your neoadjuvant chemoradiation therapy, should you pick something else as your adjuvant treatment? We don't have the data to tell us which way to go with that yet, but some people will follow their instincts and choose something different.
Right. So we don't know for sure whether if you fail one chemotherapy regimen, whether switching to an alternate regimen is going to make a whole lot of difference, or whether that person should just go straight to surgery and forget systemic therapy completely.
Well, so the CALGB has actually been looking at that, as well as Municon looked at that with
Right.
PET scans. So doing PET scans early on within the chemoradiation therapy course. And what they did is they took patients who were progressing on those early PET scans by a certain SUV cutoff and then switched them to a different chemotherapy prior to surgery. It didn't tell us that that should be our standard of care yet, but it certainly was thought-provoking enough to lead to further trials to be done to delineate this.
Right, so still a lot of unanswered questions
Correct.
in that area. Well, let's move on. Probably the most exciting area in oncology these days is molecular targets and especially druggable targets and new agents, whether they be monoclonal antibodies or small molecule inhibitors. And you gave a very nice review today about where things stand in upper GI malignancies, esophagus and EG junction and gastric. So we're all familiar with the TOGA trial, and HER2 positivity seems to be somewhere in the range of 15 to 25% depending upon the location. But what else is going on in patients who are HER2 positive? And then the other question is, how do you define HER2 positivity? Because it seems like there's some controversy as to whether or not you use the same criteria as in breast cancer as opposed to a different way of looking at things.
Right, so we're having to relearn a lot of things within gastrointestinal oncology in regards to HER2 positivity. And we had talked today in the meeting about how in some ways we're following breast cancer HER2 positive patient drug development. But should we follow it or can we follow it completely, given that we're dealing with a different tumor type here? And I think there was a very nice discussion by Howard Safran in his talk about different staining patterns for HER2 in gastric versus breast cancer, and about how gastric cancers seem to stain luminally rather than more completely as breast cancer seem to stain. And so a patient that might be considered HER2 negative who's got breast cancer may be IHC HER2 positive for gastric cancer. And so is what's positive and what's not positive. We also saw some very interesting breakdown of data showing that the patients who benefit the most from anti-HER2 therapy are probably IHC3 positive and FISH positive, and to some extent IHC2 positive and FISH positive. And these other patients that are FISH positive but IHC1 plus might not be really reaping the benefits of therapy. And we've seen that from breakdown in the TOGA trial. And we also saw some data from the TITAN trial, which is a second-line paclitaxel plus or minus lapatinib that was shown in the poster session. And overall, the survival was not improved with the addition of lapatinib for these patients. But when you break down to the HER2 3 positive, that's when the data started to change and the curve started to separate even more.
Right, that trial had like 35% of patients were IHC 0 or 1 plus, even though they were FISH positive.
Exactly.
So those patients really didn't have a fair shot at it.
Right, and it sort of seems that if we're going to start using anti-HER2 therapy, do we need to be better about defining who should get it? And I think that these trials that are upcoming are really going to start to lower down who receives the maximal benefit from these treatments.
So there's been a lot of excitement in breast cancer with pertuzumab now being approved, and the monoclonal antibody drug conjugate TDM1 is sitting on the bubble. I think what is the status of those drugs? Are they being looked at in esophageal, gastric, and gastric adenocarcinomas?
Absolutely, positively. We already have trials going on with both of those agents. So pertuzumab, the anti-HER2, HER3 drug, which is combined with trastuzumab, shows more benefit than trastuzumab alone. And so we're looking at pertuzumab, starting some trials there. And then we're also starting trials with TDM1, which is the antibody drug conjugate, which links trastuzumab to a toxic chemotherapy, which is misantine, and allows for targeted delivery of that chemotherapy to HER2 positive cells.
So this requires internalization of the antibody drug conjugate. Yeah. So if this works so well in breast cancer, and we see this in a lot of other malignancies, there are all kinds of antibody drug conjugates now brentuximab vedotin in lymphomas. In EGFR, with EGFR expressors, is the antibody is the receptor not internalized when cetuximab binds to the EGFR receptor? Because it would seem like a natural thing to link a toxin to cetuximab and internalize it, and especially in cells that have a significant amount of EGFR overexpression.
You would hope so. I mean, EGFR expression rates in esophageal gastric cancer is like 50 to 70%. Yet we've seen no benefit from cetuximab, panitumumab, and now gefitinib for these patients. And so I don't think anybody has put an antibody drug conjugate to cetuximab in the clinic yet, but I think it would be worth seeing whether or not you could get some sort of internalization that would allow for targeted drug delivery.
Right, because there is, as you said, significant overexpression. You don't see the mutations that are seen in non-small cell lung cancer, but amplification is there, and so somebody must be working on it.
I hope so.
So while we're talking about EGFR, there was a presentation today on gefitinib, and gefitinib's been tried, and even though the quality of life seemed to be improved, the responses and other parameters, overall survival, just don't seem to hit the mark. What do you think is the problem?
I think there may be a couple of problems. First is that the study was done in second-line gastric cancer patients who tend to have a poor overall survival. They tend to be sicker than the average patient. So the amount of treatment that you can get into them is maybe not as much as in the first-line setting. The other thing that we saw is that there may be a very, very small subset of patients that could potentially receive benefit. So when you look at the overall survival curves, there was no difference. But when you look at the progression-free survival curves, there was a difference, and it seemed to be better with gefitinib than best supportive care. But it also seemed that the curves seemed to separate into a biomarker type curve.
Right.
Now they're going to run biomarkers for this study, and when you look at the responses, there were a few patients that had some better responses, as well as potentially those were the patients that received the benefit from quality of life. And so what we're waiting to see now is there a subgroup of patients that did benefit? But I think akin to what we just spoke about, it's not going to be a traditional biomarker that we're used to looking at. We don't see the EGFR mutations. We don't see the PI3 kinase mutations. So maybe this is going to be something different, protein expression, something different that's going to be the biomarker for these patients.
Interesting. What about angiogenesis? I mean, everyone was very excited about the possibility that bevacizumab would have significant impact in gastric cancer. But the Avogast trial was, officially negative, although there was a difference in the geographic populations. What is going on in that era? There was Charlie Fuchs had a presentation today with ramucirumab, a VEGFR2 inhibitor. So where are things headed as far as angiogenesis targeted therapy in upper GI cancers?
Well, I think what we all learned from Avogast was a very strong lesson that depending on where in the world you live, it's going to make a difference to how you should be treated. Because when you broke down Avogast, people within the Americas seemed to have a benefit from bevacizumab added to chemotherapy than those in Asia. And that's probably because they're different tumors. We do know that the intestinal type tumor is more prevalent in Asia, whereas the more diffuse and more poorer prognostic tumors are in the United States and the Americas. So could bevacizumab potentially help chemotherapy better for those patients? Is there a genomic difference? We don't know. And so with the ramucirumab data that we saw, which was second-line ramucirumab versus best supportive care, there was a positive survival difference and progression-free survival difference. And so that really tells us that anti-angiogenic agents probably do help in gastric cancer patients. But again, we're coming back to that same old story of they probably help a specific population, and maybe we need to target our targeted therapies to a certain population.
Right, and even I know in colon cancer, bevacizumab had very little activity as a single agent, but when combined with chemotherapy, there was significant benefit. Is ramucirumab going to be combined with docetaxel or irinotecan in second-line therapy to see if the benefit would be augmented?
So we're waiting for the results from the Rainbow trial. So this was a second-line gastric cancer trial where they randomized patients to paclitaxel weekly versus paclitaxel plus ramucirumab, and that was a randomized phase 3 study. We're waiting for those results. And they also looked at it in the first-line setting. And so within the Americas, they randomized first-line esophageal gastric cancer patients to FOLFOX plus or minus ramucirumab. So I think those two trials will further build on what we're looking at from the REGARD study.
So will we have results by ASCO, or?
I don't know if Rainbow's going to be ready for ASCO. I know that the first line study is probably not, but I'm hoping sometime within the next year we'll have both.
Very good. Well, that'll be interesting because that's a much more focused agent just hitting VEGFR2. So that'll be very interesting. So what about some of the other pathways? I know that you mentioned PI3 kinase, AKT, mTOR. mTOR has been looked at with the GRANITE-1 trial. AKT didn't do so well in colon cancer, but is AKT blockade, does it have potential in upper GI malignancies?
Oh, sure it does. Looking at AKT, so we do know that there's dysregulation of the PI3 kinase pathway. We also know that AKT has the potential to synergize with chemotherapy or prevent resistance mechanisms for chemotherapy. So right now there are trials in design about to open that are going to look at combinations of chemotherapy with AKT inhibitors within gastric cancer patients.
All right, and is mTOR a dead topic? The GRANITE trial with everolimus did not seem to be positive, but theoretically it seems like that whole pathway is sort of an escape mechanism. Is that going to move forward with other inhibitors?
So, it's interesting when you look at the progression-free survival data for everolimus in the GRANITE study, it also looked like there's a potential subset of patients that may have benefited. And then you also start to think back to gastric or to breast cancer again. We have the Bolero trials, and one of which is looking at trastuzumab plus or minus everolimus. And so it makes you wonder about, and we were joking in the session about the Bolero trials, if we need to start looking at it in gastric cancer as well, trastuzumab plus or minus everolimus.
That will be interesting, yeah. Blocking two pathways.
Yeah.
That'll be very good. All right, then what about c-Met? I mean, we hear about c-Met in so many different solid tumors that this receptor tyrosine kinase has an ability to heterodimerize with other RTKs on the cell surface, and it seems like with blockade, c-Met gets amplified. So are there c-Met mutations that are significant, or is it a matter of overexpression and amplification? What is the story in upper GI cancers with c-Met?
So all of the above.
Okay,
so,
good.
so within cancers, we've seen mutated c-Met receptors, we've seen amplification, and we've seen overexpression of the ligand. Within GI cancers, we've seen a number of randomized phase 2 studies now come out looking at attacking the c-Met pathway, and particularly as we've seen with non-small cell lung cancer as well, the benefit appears to be for patients who are c-Met high, which is overexpression by immunohistochemistry. And so what we're starting to look at now is that within gastric cancers, can we build on this further? So we're looking at AMG 102, which is rilotumumab. It's a ligand, the HGF blocker, where we saw some very good preliminary randomized phase 2 data, now moving into randomized phase 3 in the first-line setting for esophagogastric cancers. Genentech's METMAB or onartuzumab, which is a one-armed antibody that binds the MET receptor, is also being investigated in gastric cancers. And so there's a lot moving forward.
So by being one arm, it doesn't cause dimerization.
Correct.
And then so blocks the signaling. Okay.
Correct. And then you also start to think about, as we've seen in non-small cell lung cancers, can you combine anti-MET with other receptor tyrosine kinase inhibitors like they used erlotinib in non-small cell lung cancers? Could we start to use those in combination within other GI cancers as well? And I think that we'll see some data hopefully at ASCO looking at tivantinib, an anti-MET receptor in colon cancer in combination with cetuximab and irinotecan.
The small molecule TKI.
Exactly.
Well, that's interesting. And you know, when you look at all the data coming through on a lot of the solid tumors, especially in non-small cell lung cancer, it seems like every 6 months they discover a new mutation that affects 1% of non-small cell adenocarcinomas, but that turns out to be 20,000 people or so. And there is a blocker available, whether it's crizotinib or one of the other drugs. Is there any progress being made in upper GI adenocarcinomas to identify specific molecular targets and mutations that seem to be the oncologic drivers of a certain percentage of the cancers?
Unfortunately, we have not been as lucky as lung cancer patients to find those specific mutations. Right now we have HER2, and we have some other ones that appear to be things to try to target, like c-Met high patients, or even patients with PI3 kinase mutations. People are also starting to look at FGF or fibroblast growth factor mutations within gastric cancer patients, but none of them are ready to hit prime time yet with any good significant clinical data outside of HER2.
Well, thank you so much once again for being with us. I hope you enjoy the rest of the meeting and enjoy San Francisco. It was raining yesterday, but the sun has come out this afternoon, so that's very encouraging.
Thank goodness.
Absolutely. And thanks to all of you for watching this session of Best of the Day from the 2013, the 10th anniversary ASCO Gastrointestinal Cancer Symposium. Stick with us. There will be much more to come throughout this 3-day meeting. Thanks again.